Again, I want to welcome those of you who are joining our webinar. And again, I'm very proud and privileged to say that this webinar is brought to you by Biogal, the LED Labs. Before I introduce our speaker, I wanted to say, and we already have folks who are saying hello. So hello, Portugal, thank you. One of the things I wanted to mention is that we will be utilizing the chat box. So as Dr. Netta, our speaker, is presenting, and as you have questions, please enter them in the chat box. I will be accumulating those questions, and then when we get to the Q&A session for the last 15 minutes of today's program, I will be presenting your questions to Dr. Netta for answers. Additionally, I wanted folks to know that halfway through the presentation, we are going to please answer those two questions that are presented, and then you will be able to continue enjoying the presentation. The other point that I wanted to make before I introduce Dr. Netta is that a recording of today's presentation will be available. You will all be receiving a link so that you can see this presentation for future viewing. It brings me great pleasure to introduce Dr. Revital Netta, who holds a Bachelor of Life Sciences degree from Ben Gurion University of the Negev, and was awarded a Doctor of Veterinary Medicine degree from the Koret School of Veterinary Medicine at Hebrew University of Jerusalem. She is a practicing companion animal veterinarian through medicine and surgery. Additionally, besides her veterinary practice, Dr. Netta supervises the regulatory affairs and product management activities at Biogal. She serves as the medical advisor and provides clinical support and training to Biogal's customers. It brings me great pleasure to introduce Dr. Netta. Revital, would you like to take over?
Thank you, Dr. Han, for presenting me, and thank you for all attending. Now, I would like to actually begin by presenting myself just a little bit different. I would like to show you actually my home, where I'm from, and also Biogal's location. This is Kibbutz Galed. A kibbutz is a type of settlement here in Israel. Among thriving landscapes we have around here, we also have a lot of animals, such wild and farm animals, and also domestic animals. We have around 150 families here in the kibbutz. We have 60 of them with domestic dogs, around 50 with domestic cats, and around the kibbutz we have more than 50 of feral cats. And now more than most of those dogs and cats are under my closest treatment. So this is just a bit of the practicing I got to do living in that kind of area. So now moving forward to Ehrlichia Canis and the in-clinic diagnosis of it, I would like to actually begin with those images. I would like to ask you to take a few seconds and take a look of those images, and please think is what you think you see it is actually what you see. I think it's something that as doing diagnostics, it's something that we asking ourselves quite a lot. We have this kind of suspicions of something, and in order to get forward and to make these suspicions confirmed, we're providing all these kind of steps, which would get us closer and closer to the final confirmation of what we're suspecting of. When speaking about infectious disease in particular in diagnosis, so part of those steps are, first of all, the history, the compatible clinical signs, the compatible physical examination findings, then going forward to those laboratory findings. But there is one more step that could bring us as close as possible to this final confirmation, or for at least almost 100% of it. It's those other extra and further testing, such as serology and molecular testing. There's more tests, of course, but those are tests that can be available in the clinic, and we'll talk further on about this molecular testing technology that I would like to present to you today as well. During the lecture, we will run into these three cases that will help us go deeper and to understand it fully, canine ehrlichiosis in clinic diagnosis. We will begin with Argo. Argo is actually a dog that arrived to a colleague of mine. We treated him around 3 years ago. He is a 4-year-old male border collie. He's a working dog. He came with a history of tick found on his body, with no prophylactic treatment for ticks or fleas, with a chief complaint of lethargy, anorexia, and mild depression. At this point, in the physical examination, my colleague found high fever and lymphadenomegaly. She performed a CBC, which got her closer, one more step into confirming her assumption. She found thrombocytopenia and a mild non-regenerative anemia. In the blood smear, she couldn't find any pathogens. Now, because Ehrlichia Canis being the most common vector-borne pathogen in Israel, and because of the owner asked for my colleague to try and cut expenses as much as possible, my colleague decided to begin a treatment with doxycycline once a day for 28 days with a 10 milligram per kilo as a dosage. And of course, she asked for checkups for a checkup in a few days. Few days after, unfortunately, he came back with aggravation of all clinical signs. In the physical exam, she noticed pale mucous membrane this time. She performed the glutathione test that came back positive. And in the CBC, this time, aggravation of the thrombocytopenia and the non-regenerative anemia. The biochemistry showed elevated CK and LLP and a high total protein and globulins. At this point, Argo was hospitalized because his situation was pretty bad. She also considered autoimmune disease in addition to this vector-borne pathogen, but before any addition of any immune system, depression, she decided to send the blood for a panel of vector-borne disease PCR. And then it actually came back from Ehrlichia Canis positive. Perhaps we're talking about a case with co-infection, perhaps other vector-borne disease pathogens. But at this point, she began with ImmunoComb and some immune suppressive drug. Unfortunately for Argo, he did not make it. His situation was too bad. But I think in general, it's kind of showing us how this disease and other vector-borne pathogens can be a bit complicated, can be a bit tricky because of having so many clinical manifestations, has different phases, and the fact that they can be a co-infection between other vector-borne diseases, pathogens. It is complicated, and that's why perhaps this whole situation can be avoided, and that's why we have those steps and into the final confirmation, for at least the one that will bring us as closest to that. We have those tools of extra tools that could help us with the diagnostics. On today's lecture, we're gonna divide it into two. The first one, point of care diagnostics, just the definition of it, and those point of care diagnostic tools that are available in the clinic that are for dealing with infectious diseases such as serology and PCR. And then for the second part, we're going to use those diagnostic tools and show how there is a practical use on the steps of diagnostic of Ehrlichia Canis. So let's move on to the first part. Point of care, meaning it's a near patient testing. We have the chance of making an investigation while the patient and owner are waiting outside. It gives us a prompt assessment that we can give to the owner, a fast diagnostics, and of course, a fast treatment that is a great, great advantage for both the owner and the pet. And of course, for being such kind of a test, it needs to be fast enough. We still have the owner waits outside. It needs to be relatively simple because it's something we're doing in between doing other things. If it's the technician or the vets, we need to have it relatively simple and accurate based on scientific knowledge, on scientific facts, and affordable, of course, both to the owner and to the vet. So when talking about those point of care tools that there are available, we're talking about two technologies. One of them is serology, and the other one is PCR. I would present it to you later on. When talking about serology, we're talking about detection of antibodies in the blood, meaning we would look for them in serum, plasma, or whole blood. When talking about PCR, we're talking about detection of the pathogen itself, meaning that we can find it whenever the pathogen is, such as whole blood, bone marrow, lymph node, and etc. Now, there is a few main features that we should remember. When using serology, remember it does not detect the presence of the pathogen. It cannot determine active disease because of that. Perhaps there is a previous exposure we don't know of, and that's why we will get false positive. Another false positive is those serocross reactions, especially when talking about Ehrlichia. There is a cross reaction between different species of Ehrlichia. And of course, those late responders, when looking at the first course of the disease, sometimes when performing serology, we're not necessarily going to get a positive result because of those late responders, but we will get false negative. For that situation, a PCR could be good because it's very specific and very sensitive, And so with those early stages of the disease, it could be a very useful tool. But remember, of course, it does not assess the immunological status if that needed. Now, in order to a little bit emphasize a little bit better, maybe to make it more tangible, let's look at it as a window of detection in the blood, as a schematic graph. You can see that in these early days, after the incubation of the disease, when the dog is arriving with those clinical signs, the greatest odds are to find the antigen are exactly over here. We will look for the pathogen in a molecular way at this point. The second phase, and again, because of those late responders, we can have it with a little bit of a lag. There is the IgM antibody. The IgM antibody will indicate active infection, but again, it could be of late responders. And when it fades away, then the IgG went up, is coming up. Now, when looking at the IgG, remember again, the former exposure, previous exposure. It doesn't mean if we got a positive that we're talking about an active pathogen in the blood. And that's why we need to prove fourfold rise in titer. So we need at a time when the dog is in the clinic to perform the test, and about 7 to 14 days after to perform the test one more time and to show the rise in titer. Remember that because those tests with a yes or no results would not necessarily help us out at this stage. So this is when we look in a window of detection in the blood. Just to summarize this part, when talking about infectious disease and in-clinic diagnosis, we want, of course, confirm our suspicion as much as possible. We have those tools that are point of care that's preferable to be fast, simple, accurate, and affordable, of course. And remember this timing and window of detection. When serology is proper and when PCR, maybe combining between the two, taking into consideration exposure versus actual infection. Remember those late responders and perhaps then consider PCR. And of course, taking the course of the disease, if we're talking about a disease that has phases, so also take it into consideration, and we'll talk specifically about Ehrlichia further on. Let's move on to the second part, Ehrlichia Canis and the practical use of those point-of-care diagnostic tools. Ehrlichiosis worldwide, we are talking about 3 main species, when Ehrlichia Canis would be the most common one and the most worldwide, Ehrlichia. It would be more in tropical and temperate areas. We are talking about an agent that is a gram-negative bacteria. It's a rickettsia, it's intracellular obligatory. You can find it in a morula, in monocyte or macrophage. You can see it on the right on different images. And now we must ask ourselves about the location of the rickettsia, especially when we want to use PCR. When PCR is on the table, you want to know where to look for the pathogen. Now for Ehrlichia Canis, it varies between the different phases. It could be in the blood, lymph nodes, bone marrow, and spleen, and we're going to discuss it further on. Transmitted via the brown dog tick. It could also be transmitted through blood transfusion if the animal was infected with the rickettsia. The incubation time is between 8 to 20 days, and the phases are the acute phase that can take 1 to 4 weeks. Subclinical phase, we're talking about months to years, plenty of time. Chronic phase, the same, and can lead to death because this bad situation. And from some reason, the chronic phase is more common in German Shepherd's dogs. As far as the pathogenesis of the Ehrlichia, so it all starts with the bite of a rickettsia infected tick. It continues you into the bloodstream. From there, by binary effusion, it continues into the hemolymphatic tissues, the spleen and the bone marrow. As it turns, it causes this massive antibody formation that is a part of massive immune-mediated response, which part of them are circulating immune complex, erythrocyte agglutination, antibodies against platelets, antibody versus nuclear, that can cause in their turn the vasculitis, thrombocytopenia, thrombocytopathia, and if we're talking about the chronic phase, also bone marrow destruction. So after talking about the pathogenesis, I would like to go forward and discuss these steps in order to confirm our suspicion. So the next step is the physical examination findings. So what should we expect? If we are suspecting of the acute phase, then there will be some unspecific signs such as high fever, depression, lethargy, and anorexia. Some hemorrhagic tendencies, perhaps lymphadenomegaly and splenomegaly, some ocular disorders, CNS signs, and polyarteritis. In the subclinical phase, they will be clinically healthy. They wouldn't look any sick at all. In the chronic phase, we're going to see a severe weight loss. It's a situation that's been going on for a while, and therefore they will look quite cachectic. And the rest of the signs, of course, depending on the affected organs, marked splenomegaly, hemorrhagic tendencies, glomerulonephritis, renal failure, some lungs, interstitial pneumonitis, anterior uveitis, and meningitis, and eventually even death due to sepsis and anemia because of the huge destruction of the bone marrow. Moving on to the laboratory findings. In the acute phase, the CBC of thrombocytopenia should be moderate to severe, with a mild anemia and mild leukopenia. In the biochemistry, high protein and globulins, low albumin, and with elevated ATP and ALP. In the blood smear, perhaps you're going to see reactive monocytes. Now, the finding of morula in blood smears, actually, their sensitivity is quite low. We're talking about 4% when looking at a blood smear. On the right, you can see a morula, and underneath it, there is some reactive monocytes. Now, in order to get the sensitivity a little bit higher, taking buffy coat smears, bone marrow, lymph nodes brings it higher, but in a magnification of 1,000. That in that magnification, it will require a long time to look it up. Beside of the low sensitivity, there is also low specificity because of some artifacts that could confuse a little bit the image, such as platelets, lymphocytic eosinophilic granulate, phagocytosed nuclear material, and other organisms of Ehrlichia, such those of Anaplasma family. So unfortunately, it's not necessarily a very productive tool. And of course, we're talking about the acute phase where they are in the blood and could be seen. Subclinical phase, well, the CBC will show mild thrombocytopenia of around 200, mild anemia, and leukopenia. In the chronic phase, as far as the CBC, pancytopenia, because of the destruction of the bone marrow, all the cell lines are very low. As far as biochemistry, high proteins and globulins, low albumin, and here as well, elevated ATP and ALP. And in the subclinical phase, perhaps you're going to also, if you look for those globulins, you perhaps are going to see hyperglobulinemia as well. Now, when going forward into those further diagnostic tools, those that could bring us as close as possible to confirm our suspicions, again, we're talking on molecular or serology testing. When discussing the different phases, and it's very important a fact that we need to take into consideration, because when choosing to use molecular testing, PCR, we must take into consideration the pathogen location. What sample should I take to find this pathogen? For serology, we need to know what to expect. So let's take a look over the different phases. When we're looking at the acute phase, for PCR, it will be more than enough to take the sample from the bloodstream. It is true that it was proven actually from some work that's been done with artificial infected dogs, that they noticed that the spleen is actually the organ that harvests the Ehrlichia Canis last. But as far as the acute phase, blood, the spleen does not have any advantage over the blood, and the bloodstream is enough for that. When looking at the subclinical and chronic phase, it's a little bit different. You perhaps can find it in the bloodstream with a whole blood would be enough. But if not, know that because you probably can find it in the spleen or bone marrow or some other tissues. But it not necessarily will be in the blood. Again, the spleen as being the last organ to harvest the disease would be probably the choice on those situations, although it could be invasive, and depending on the blood cells, thrombocyte, and of course the anemia, the decision will go forward from that. As far as serology, we're talking in the acute phase, it takes 1 to 4 weeks post-infection. Remember those late responders and therefore the false negative. So perhaps take into consideration of performing a PCR and not serology. And if you do choose to perform serology tests, it's the one that is available to you. remember to use another point to prove a fourfold rise in titer in order to show that it's not a previous exposure, but active infection. As far as the subclinical and chronic phase, we need to take into consideration, it's a situation that's been there for months to years, meaning that the immune system has produced antibodies for a long time, and so we would expect high antibody titer. Again, something that we cannot provide from the yes or no test, but we need to show the level that is higher than the normal. And again, to make it more tangible, what happens in the blood for Ehrlichia Canis in specifically. So when looking at those early days, when those clinical signs are appearing, and that's probably the time that the dog will arrive into your clinic, that is the time that you would probably like to look for the pathogen. It can be detectable, as early as 4 to 10 days post-infection with a PCR. Sorry guys, hi. So again, as far as the pathogen, it will come early as 4 to 10 days post-infection. As far as the antibodies, as you can see, there is no IgM available in the market at all. We're talking about IgG when talking about Ehrlichia Canis. And again, if you use IgG, you must confirm, must prove at one point a level of titer, and then at a different point, about 7 to 14 days after, you need to show this rise of fourfold in titer. Now, in those subclinical and chronic situation, you will be on this plateau. And again, you would expect a high level of titer. And if you look for the PCR in those areas, perhaps in the blood, perhaps you would find them. But if not, know that it's not necessarily mean that it's negative, but you could check it further. Perhaps could check it further in spleen and bone marrow or some other tissues. Let's make it even more tangible with those two other cases I promised in the beginning. Well, this is Litchi. Litchi is a 4-year-old female dog. She arrived to the clinic where I work with lethargy and anorexia. In the physical exam, she came with a high fever and large lymph nodes, with a history of traveling in nature and grazing field, and tick was found in her body. In the CBC, a mild anemia and a thrombocytopenia of 66, and she was suspected of acute ehrlichiosis. On the other hand, it's another case that I had, Ches, arrow in Hebrew, is a 2-year-old male German Shepherd dog. He came with a chief complaint with a significant weight loss, anorexia, and lethargy. In the blood CBC, all cell lines were low, WBC, hematocrit, and thrombocytopenia. In the biochemistry, high globulins, elevated ALP, ALT, and CK, and actually he was suspected for chronic ehrlichiosis. Before we move any forward, I would like to take this chance and to present to you our technologies for the molecular testing, also for the serology. And these tools will bring us as close as possible to confirm our suspicions from those two cases. So the first one, called ImmunoComb, it's a serology point of care kit. It's a kit that you can use in your own clinic. When you compare it to the yes or no test, we're talking about a semi-quantitative test. There is scores from S1 to S6, S1 being the lowest one, S6 being the highest one. We have a cutoff of S3, that's the control. And from that point and up, it's positive. That point and down, from down from that point, it's negative. Now, because it's semi-quantitative, you can prove the fourfold rising titer, and you can show at different levels on the different phases of the disease. I'm going to show it to you further on in the cases we talked about. Now, ImmunoComb, compared to the IFA, that is the gold standard for Ehrlichia Canis, the sensitivity that came up is 96%. And if you, versus reference lab, the ImmunoComb need a minimal training required, and the results are within 23 minutes only. Well, this is a good example because it's work that we did ourselves. You can see that as far as the S scores I talked about, from S1 to S6, and we looked also for the platelet count. When on this axis, it's weeks post-infection. You can see that around day 14 on week 2, that there is very, very low platelets that come into this low around that time, when also the clinical signs are at their peak as well. Now, if you take a look over the scores of the S, you will see that at that point, where the dog probably will arrive to the clinic, then we will get S3 results in the ImmunoComb. Looking it up a week after, it will probably going to go up all the way up here, and then you can see that there is a rise in antibodies. When looking at the subclinical and chronic stages, you can see that the scores are quite high. They will be between S5 to S6. Again, because we're talking about a longitudinal exposure to the disease, and therefore many of antibodies should be expected. To the other technology, PCR can be performed in the clinic as a point of care kit. So versus reference lab, you can see that it's in the size of the hand. This machine, it's not heavy or space occupying. It's not expensive equipment. Minimal training required. We're talking about hands-on of 10 minutes, and the results are ready within about an hour. What you see on the right, it's the heat block. It's the one that's compatible with clinics. And the final results come as a yes or no, with this dot being the control, this line being the control, and the other line being the test itself. Over here, it's positive, and this one is negative. This one is the PCR reader. It's more compatible for use in labs. Same idea, very small, just the results comes a bit different. As far as performance and accuracy of this technology, with the heat block, we're talking about sensitivity of 100% and specificity of 99.3, compared, of course, to the real-time PCR of Tuckman, as well for the reader, 97% and 100%, with a same comparative method of Tuckman real-time PCR. Now, let's make it even more tangible and show you exactly how to implement those tools. So I remind you, lychee was suspected in acute ehrlichiosis. We performed the IgG ImmunoComb for ehrlichiosis on day 0 when she just arrived to the clinic. You can see that the dot on the top is the control dot. The dot on the bottom is the test itself, and it became darker than the one on the top. It's actually read for S4, when this one read as S3. 10 days after, we rechecked lychee and found that the dot turned from S4 to S5. So actually, it got stronger, meaning that the titer has a fourfold rise in it. As far as the PCR, we performed the PCR as well on day 0, and it turned back positive. So If you use the serology, again, you need to prove a seroconvert, you need to prove a fourfold rise in titer, and with PCR, just one testing point. And if we're talking about the acute phase, you will find it in the blood. As far as Hetz, our German Shepherd dog, suspected for chronic Ehrlichiosis, we tested him with IgG ImmunoComb, and it was S6. It was pretty strong. And with PCR, you can see it actually came back negative. I would like to remind you that in those situations of chronic Ehrlichiosis, it not necessarily would be fine in the blood. Now, in this point, Hetz continued his hospitalization and further diagnostics in the Hebrew University in Beit Dagan, where they confirmed chronic Ehrlichiosis and treated him with everything possible. And actually, Hetz, because his situation was kind of in a border to be moderate, he actually made it and still alive until today. I'm happy to say that. So just to summarize all that we talked about, all those steps into in-clinic diagnosis in this very complicated disease, as we said in the beginning, many clinical manifestations, different phases, and as well co-infections to get forward and to get into the most closest confirmation to the final confirmation as close as possible. Need to begin with the compatible history in clinical science, compatible physical examination, and laboratory findings with, of course, with the relevancy to the different phases. And for the final confirmation, serology and or molecular testing, the PCR. Think about the window of detection when PCR and when serology. When using serology, think about the false negative in early responders and perhaps consider PCR instead. When deciding to use serology, if it comes out positive, remember previous exposure and the fourfold rising titer that needs to be proven. PCR, when acute phase, it's enough to look for it in the blood. In the subclinical and chronic phase, the spleen will be the best place to look for it. Actually, the greatest odds to find it, but also can be found in bone marrow and blood. And another thing to consider, perhaps a combination between the two, just to make it more tangible. When using a serology and it came back negative, if it came back positive with PCR, you're talking about acute infection. If it came back negative, then it's possible other cause. When the serology is positive, then by running a PCR, it came back positive, current infection, no doubt. When it's negative, then perhaps we're talking about previous infection, chronic infection. Of course, we're talking about in the blood, chronic or subclinical infection, and recovery. Now, this is something that I'm not going to go through, but you're going to have it just to use it whenever you want. It's everything I talked about, beginning with those clinical signs and physical examination, and in toward the blood count and what to expect from it, the biochemistry, serology, and the PCR. So you have it all summarized here. As Dr. Hans said, you're gonna get all this presentation and the recording sent to you as we finish this webinar. So I'm going to finish with this saying of Gandhi: a correct diagnosis is 3/4 the remedy. So that's it.
When we receive that. And Dr. Netta, I wish you could see in our chat box here, it's just being flooded with people thanking you for a wonderful presentation. So thank you, Dr. Netta. Thank you, Yotam, for your great engineering.
Thank you for
and
all
folks,
Goodbye.
Have a wonderful day, folks. Thank you.